Hello, this is Dr. Kalayou from Ethiopia. I am a principal investigator of this experimental study. The title is about effect of motivational intervention on glycemic control, diabetes distress, and self-efficacy among adult people diagnosed with type 2 diabetes in Tigray, Ethiopia. The presentation outline is introduction, objective, method, result and discussion, conclusion and recommendations, and acknowledgement. In the introduction, as you all know, diabetes is a metabolic disorder caused by either insulin resistance or deficiency or both, and characterized by hyperglycemia. Diabetes is a major threat to global public health and a major source of morbidity, mortality, and increased healthcare cost. In 2024, the prevalence of diabetes was globally 11%, Africa 5%, and Ethiopia 4%, according to IDF report 2024. In 2022, however, a meta-analysis revealed that national diabetes prevalence among adult Ethiopians was 6.26%. If not managed properly, diabetes could result in chronic complications such as nerve damage, stroke, coronary heart disease, peripheral arterial disease, kidney failure, and retinopathy. Furthermore, severe diabetic-related distress affects 25%, 20%, and 10% of type 1 insulin-treated type 2 diabetes and non-insulin-treated type 2 diabetes patients respectively. High diabetes-related distress could result in poor medication adherence, glycemic control, self-efficacy, unhealthy eating, and physical inactivity. Self-efficacy plays a crucial role in various health behavior, including smoking cessation, weight management, nutrition, alcohol consumption, and AIDS prevention. Similarly, self-efficacy is a key factor influencing the effectiveness of diabetes control via self-care practice. It is essential for adhering to self-care recommendations in order to maintaining physical well-being. It's also able to maintaining physical well-being. Major components of self-care practice are healthy diet, physical activity, blood glucose monitoring, drug adherence, and food care. Those behaviors are positively correlated with good glycemic control and prevent complication, increase life expectancy, enhance quality of life. However, effective self-management is dependent on a person's level of motivation and on the technical ability required on self-care practice. Lack of technical skills, low motivation, and limited supply of essential resources contribute to poor adherence to self-care practice. For example, in Ethiopia, more than 60% of patients had poor glycemic control, and only 50% of the patients perform self-management of blood glucose as recommended. Another study showed that in Ethiopia, 46% of patients had summarized diabetes self-care activity score below average. So, behavioral interventions such as motivational interviewing enhances patients' self-efficacy related to diabetes management by solving ambivalence for change. Motivational interviewing is a client-centered counseling style or technique for strengthening and increasing patients' internal motivation for change through identifying and addressing their ambivalence. Moreover, motivational interviewing improves patients' perception of the need for behavioral change and supporting them in making positive change. MI motivational interviewing focuses addressing obstacles to change by emphasizing the advantage of change and the disadvantage of staying the same. However, some studies reported mixed results. For example, one study showed that significant hemoglobin A1C reduction in the non-MI group or motivational group, and another finding revealed that there was no additional benefit of MI over usual care. Moreover, most researchers focus on effect of diabetes self-management education despite the adaptability of MI across diverse cultures and clinical settings. Similarly, majority of researchers in Ethiopia focuses on diabetes prevalence, self-care behaviors, dyslipidemia, and glycemic control, with limited evidence on effect of MI on patients' health outcome. Moreover, despite its growing international use across healthcare domains, MI or motivational interviewing effectiveness among Ethiopian diabetic patients' health outcome remains uncertain and unresearched. In addition, the reviewed studies have some methodological limitations, such as use of unvalidated data collection tool, small sample size, and poorly defined outcome measures. Furthermore, little is known and not adequately investigated about the effect of MI or motivational interviewing on glycemic control, diabetic-related distress, and self-efficacy among patients, among diabetes patients, and no study has been carried out in the study area or in Tigray. The rationale of the study. Finding of the study will be important for healthcare providers to identify their role in enabling patients to overcome diabetes-related complications. And it's also important for healthcare providers to develop strategies to clarify and modify diabetes care, implement client-centered education and counseling. It's also important for healthcare professionals to improve communication skills and motivate patients to adhere or to advise a desired behavioral, to achieve desired behavioral changes. Finally, this study is also important for contributing a new knowledge to the scientific world and nursing profession. So this is a conceptual framework or theoretical framework based on health belief model. So we have this the individual factor, like the socio-demographic factors, the clinical factors, the psychosocial factors, plus the intervention, which is the motivational interviewing, plus the routine diabetes self-management education. So these have an effect on the patient's knowledge and skill of self-care practice, knowledge on risk factors of chronic diabetes complication. So having this, if these are positively affected, there might be an effect on perceived susceptibility to the chronic diabetes complication. There is also an effect on perceived seriousness of DM and its complication. There is also an effect on perceived barriers of self-management, confidence in doing self-care process, and cue action. So these are the modifying factors. So if that of these factors, the modifying factors are if it is affected positively because of the intervention, in the outcome, we will have reduced hemoglobin A1C, reduced diabetic-related distress, and increase self-efficacy for self-management, diabetes self-management. So this is a conceptual or theoretical framework that guides our study. So this is the objective of the study. So the general objective was to evaluate the effect of motivational intervening on glycemic control, diabetes-related distress, self-efficacy for diabetes self-management among type 2 DM patients in Tigray, Ethiopia from 2023 to 2024. The specific objectives were to examine the effect of MI on hemoglobin A1C level among type 2 DM patients, to evaluate the effect of MI on diabetic distress among type 2 DM patients, to determine the effect of MI on self-efficacy among type 2 DM patients. So the methods that we are using for this study area is in two hospitals that are found in Maqala City, Tigray region of Ethiopia, which is Eider Comprehensive Specialized Hospital and Maqala General Hospital. So the study is done in two hospitals, public hospitals. The study design is quasi-experimental study design. The study period is the baseline assessment was done from November to December 2023. The intervention phase was January to June 2024, which is for 6 months, and the endline assessment was July to August 2024. So the eligibility criteria was all type 2 DM patients aged greater than 18 years and above and had follow-up for at least 1 and above years. The sample size was a total of 160 type 2 DM patients were included in the study, which is 80 per each group. So the sampling procedure where a systematic random sampling method was used to select or recruit the participants. The data collection tool, questionnaire were used, and there is also a standardized validator tool, which is a paid problem area and diabetes scale that is used to measure the diabetes related distress, and diabetes self-efficacy scale is also used to measure the self-efficacy of the patient in relation to their self-care management. The variable, there were demographic variable or factor, clinical factor. There are also laboratory measure, which is hemoglobin A1C, diabetic related distress that is measured by paid scale, and the self-efficacy that is measured by DSE scale. So the intervention group participants in this group were received MI or the motivational intervention monthly for 6 months for 15 to 60 minutes long. By the way, this intervention group were selected from DM patients who had follow-up in Eider Comprehensive Specialized Hospital. So Eider Comprehensive Specialized Hospital was the intervention site, whereas the control site were the Maqala General Hospital. So the control group participants in this group received diabetes education or the usual care, but do not incorporate or do not have principles and strategies of MI. So the only difference between this group is in the intervention group, the education were delivered using or incorporating principle and strategy of MI. But in the control group, the routine or the traditional diabetes education were used. So lost follow-up, to reduce lost follow-up, participants were received a reminder call 1 to 3 days prior to their next appointment. The data analysis was done using SPSS version 20 and Stata version 17. Then the categorical data type were analyzed using Pearson's chi-square test, and continuous data were analyzed using non-parametric tests like Wilkinson, signed rank, and Mann-Whitney test due to non-normal distribution of the data. In addition, a DID or difference in difference analysis method or DID regression analysis was done to assess average treatment effect. So statistical significance was set at 95% confidence interval and a p-value of 0.05. The ethical consideration, ethical clearance was sought from IRB of Maqale University College of Health Science of Ethiopia. Support letter was gained from Maqale University College of Health Science to Tigray Regional Health Bureau, and from Tigray Regional Health Bureau, support letter were sent or received to the respective hospitals in order to get permission to carry out this study. After explaining the study's aim, the study participants give their informed consent, written informed consent, to indicate their willingness to participate. Participants were not exposed to any risks apart from the time spent during the interview for participating in the study. Benefits and confidentiality were maintained throughout the study. So the result and discussion, the baseline participant characteristics, there were no significant difference between the two groups in the baseline characteristics, which means before the intervention, except for marital status, diabetes treatment regimen, and fasting blood sugar level. At baseline, which means before the intervention, 80% of participants were aged 51 to 70 years, with similar distribution across the group. Regarding marital status, the control group had more single participants, while the intervention group had more widowed participants. Furthermore, more participants in the intervention group were unemployed, and the majority of participants of the intervention group lived with their family. At baseline, a higher proportion of participants in the intervention group were treated with both insulin and oral hypoglycemic agent. Similarly, intervention group had slightly higher median value for BMI, diabetes duration, fasting blood sugar, and systolic blood pressure. However, median diastolic blood pressure was slightly lower in intervention group compared to the control group. So we also try to prepare a theory of change for the intervention. So the intervention, we have this input, the activity, the output, and the outcome. So in the input, we did motivational intervention for the intervention group, or the diabetes education is given for the intervention group participants based on the principles and strategy of motivational interviewing. So as a result, there is resolve ambivalence were resolved, strengthen internal motivation were strengthened, collaboration was enhanced, and barriers were addressed. So the activity that was done during the intervention phase for the participants from the intervention group were key techniques of MI were done, like open-ended questions, affirmation, reflective listening, summarizing, and collaborative goal setting were done. These are some of the activities, major activities that we were done during the delivery of the intervention, the motivational intervention. The output that we get, the immediate outcome or the immediate output that we get is diabetes self-management knowledge of the participants were increased, internal motivation were strengthened, ambivalence were resolved, self-care practice were improved. So the outcome, which is a desirable outcome of this motivational intervention that we get, is there is reduced hemoglobin A1C in the intervention group compared to that of the control group. There is also reduced diabetic-related distress, similarly in the intervention group compared to that of control group, and there is also improved self-efficacy for diabetes self-management. So this is within group, between group comparison. In the hemoglobin A1C, when we see there is a significant reduction of hemoglobin A1C in the intervention group compared to that of the control group after the intervention. Similarly, there is also a significant reduction of diabetes-related distress in the intervention group compared to that of the control group, still after the 6 months duration of motivational intervention. However, there is an increase diabetes management self-efficacy or self-efficacy for self-care, diabetes self-care management, a significant increase in the intervention group compared to that of the control group. In line to this, in relation to the hemoglobin A1C, in line to this study by 3 scholars, Dogru 2019, Momontaz 2018, and Coral 2020, Berhe et al., which is a systematic review that is done by ours 2020 and Belgian et al. 2020, found that there was significant reduction in hemoglobin A1C following MI. However, study by Ismail 2018 and Rosenberg 2011 reported that MI did not reduce hemoglobin A1C in intervention group, but a study by Lee 2014 found that there was reduction in both groups with no significant difference between them. In relation to the diabetes-related distress, similarly, like our studies by Lee 2020, Knight 2004, and Belgian 2002 identified that a paid score, which is a scale that is used to measure the diabetic-related distress, was significantly improved in intervention group compared to control group. In relation to the self-efficacy for diabetes self-management, in line to this study by Hemiti 2021, Cheney 28, and by those studies done by those 3 scholars, found there is statistically significant improvement in self-efficacy for diabetes self-management score in intervention group compared to that of control group. This is also DID analysis. Similarly, the DID analysis shows that there is a significant reduction in hemoglobin A1C, a significant reduction in diabetes-related distress, but a significant improvement or increase in self-efficacy for diabetes self-management in intervention group compared to comparison group or control group. So this is also supported to the Wilkinson analysis or the non-parametric analysis. The study limitations. Several limitations should be considered when interpreting the finding of this study. First, the sample size of both groups were relatively small, that may limit the generalizability of the finding. A large sample size would enhance statistical power to allow more robust conclusion. Second, the study was conducted over 6 months. A long follow-up period may be necessary to detect sustained change in glycemic control, diabetes distress, and self-efficacy. Third limitation, despite effort to minimize contact, participants from both groups may have shared information during social interactions, like wedding. They are living in the same city, although the city is a very big city and they are scattered. Our selection is from scattered districts, sub-districts, but unfortunately they might be social gatherings like wedding and other type of social gatherings. So at that time there might be sharing of information that may result in potentially influencing the result or information contamination. Further, fourth limitation, respondents related to behavioral factors might be influenced by the desire to provide socially acceptable answer. This is social, although we are trying to design different types of methods or strategies to minimize social desirability bias or respondents bias. There might be minor or minimum amount of respondents bias in relation to those behavioral factors. Finally, the DID analysis assumes parallel trend between groups, but this could not be tested due to lack of multiple pre-intervention point of measurement. So in conclusion, this study found that motivational interviewing was associated with reduction in hemoglobin A1C level, decreased diabetes-related distress, improved diabetes management self-efficacy. Those changes were observed among individuals in the intervention group compared to the control group. So the recommendation, policymakers should consider integrating motivational interviewing principles and strategies into the routine diabetes self-management education and support program to address the poor glycemic control. Healthcare professionals should be trained in how to provide MI-guided diabetes self-management education and counseling. The hospitals need to create an opportunity for using the MI strategies for diabetes education for intended lifestyle modification. Further research is needed to investigate the long-term effect of MI, how MI can effectively integrate into clinical practice. Acknowledgement. First, I would like to express my sincere gratitude to my supervisor, Professor Haftu and Professor Lilian, for their wholehearted support, guidance, and encouragement throughout this study. Secondly, I'm indebted to Magala universities for their modest financial support. Third, I would like to extend my heartfelt thanks to the staffs of participating hospitals for their cooperation to access their documents and supporting during data collection process. Last but not least, I want to acknowledge the data collectors, supervisors, and the study participants. And thank you.